Before we starting with cardiology disease, we must know the physiology of the fetal circulation, which is very important to understand the subsequent mechanism and pathophysiology of the cardiac disorders in the fetus, then in the neonate. Because there is many changes which is occur in the early life immediately after delivery, which is change the cardiac output from the intrauterine life to the extrauterine life. In the fetal circulation, the placenta is responsible for the gas exchange, while the lung is functionless. There is no any function for the lung in the intrauterine life. The gas exchange is done completely by the placenta. Lung are, as I said, functionless, and pulmonary vessels are vasoconstricted, shifting of the blood away from the pulmonary circulation. Because of the severe vasoconstriction or complete vasoconstriction of the pulmonary circulation, the pulmonary vascular resistance is much higher than systemic vascular resistance in the fetus. And this will result in the shifting of the blood from the lung or pulmonary circulation to the systemic circulation because of the gradient in the vascular resistance. As you know, the blood is flow from the high vascular resistance to the low vascular resistance. So because of this very high pulmonary vascular resistance, because of the vasoconstriction, so the blood will be shifting away from the lung in the fetal circulation. Right and left ventricle present in the parallel circuit in the fetus, rather than series circuits as in the newborn or adult. What I mean by this? In the fetal, in the adult, or in the extrauterine life, as you know, the blood will be drained from the venous circulation of the lower part of the body and upper part with the inferior and superior vena cava to the atria, right atria, then to the left atria, then it will be shifting to the lung, then through the pulmonary artery, then it will be returned to the left atrium through the pulmonary vein, and then it will be shifted through the mitral valve, the left ventricle, then from the left ventricle, it will be shifted to the through the aorta to the whole part of the body. While in the fetus, the pulmonary circulation or the right side of the heart circulation, it will be bumped only to the right side, to the upper part of the body, and then it will be back to the right. And the left circulation, it will be bumped to the through the left and return back to the left. There is no communication between the right cardiac output and left cardiac output. This parallel circulation is achieved by the three cardiovascular structures which are present in the fetal life. What these are structures? The first one is ductus venosus, next one here foramen ovale, and the third one ductus arteriosus. These three structures are important for the maintenance of the two parallel circulation in the fetus without communication between the pulmonary and systemic, between the right cardiac output and left cardiac output. To understand the fetal circulation, okay. This is the picture of the fetal circulation. This is picture of the fetal circulation. The blood, it goes through the two umbilical the blood will be entered to the fetus through the umbilical vein. We have two umbilical veins and one umbilical artery in the umbilical cord. These are the two veins, and this the artery. So from the two umbilical veins, the blood will be entered to the fetal circulation. 50% of it will be goes to the liver, and the other 50% will be bypass the hepatic circulation and joined to the inferior vena cava blood through what we call ductus venosus. The ductus venosus is combined the two circulation. Okay, it was the two circulation. From the as I said, through the ductus venosus, where it will be mixed with the poorly oxygenated blood, which is goes from the lower part of the fetal body. This combined blood entered to the right
دكتور
atrium. نعم.
صوتك بعيد.
From the lower part of the body, it will be goes through the combined to the blood which is comes from the umbilical vein, it will the ductus venosus. 50% it will be in the hepatic circulation, and the other 50% will be combined the ductus venosus, where it will be goes to the superior vena cava. From the superior vena cava, the blood it will be shifted through the Eustachian tube, not as usual. It will the tricuspid valve to the right atrium. Now it will be shifted to the Eustachian valve, which is a flap of the tissue present at the junction of the left atrium with the superior vena cava. Then the blood, it will be goes to the left atrium, then to the mitral valve, to the left ventricle, and through the left ventricle, it will be pushed to the aorta, where it will be supplied the upper part of the body. While the blood, which comes from the superior vena cava, from the upper part of the body, it will be shifted directly through the tricuspid valve to the left atrium. And from the left atrium, to the right atrium, sorry, and from the right atrium, this will be blood, it will be ejected through the ascending aorta. In the ascending aorta, there is ductus arteriosus present, and this ductus arteriosus, it will be, because of the pulmonary vasoconstriction, the blood not goes to the lung. Only 5% of the blood will be goes to the lung for the maturation of the lung tissue, while the 95%, because of the very high pulmonary vascular resistance, as I say, due to the pulmonary vasoconstriction, the blood will be shifted through the ductus arteriosus to the lower part of the body, to the lower part of the body. زين؟ ما راح يروح منا لللنج, only 5% of it. We have right to left shunt. So by this mechanism, the upper part of the fetal body, including coronary arteries, cerebral arteries, and the upper extremities, is supplied entirely by the right ventricle, while the lower part of the fetal body is supplied mainly by the right ventricle without any communication between the two circulation. كل واحد يمشي in parallel circle. After delivery, ايش راح يصير عندي؟ After delivery, there are two important events will be occurs. The first one, mechanical expansion of the lung and an increase in the arterial PO2 because of the increased oxygenation of the newborn up to 100%, and resulting in a rapid decrease in the pulmonary vascular resistance. So عندنا lung expansion after crying and oxygen saturation increase, PO2 increase up to 100%, so there is rapid decrease in the pulmonary vascular resistance. Next event, which is very important, okay, removal of the low resistance placental circulation lead to, after clamping of the umbilical cord, will be resulting in the rapid increase in the systemic vascular resistance and the closure of the ductus venosus. فصارت عندنا صار عندي two events. أول وحدة pulmonary vascular resistance rapidly decrease because of the lung expansion and increased oxygen saturation. وعندنا systemic vascular resistance will be increased because of the clamping of the umbilical cord, removal of the barometric circulation اللي هو عادة resistance مالته قليلة. فصار عندي هنا صار عندي systemic vascular resistance more than pulmonary vascular resistance. فهنا ايش راح يصير عندي؟ راح يصير عندي right ventricular output ما راح ترجع to the ductus arteriosus right to left shunt to the descending aorta. لا هنا راح تروح entirely to the lung, which is result in left to right shunt through the ductus arteriosus. These two events will lead to reverse shunt through the ductus arteriosus and become left to right and close over next several days to form the ligamentum arteriosum. And the functional closure of the ductus arteriosus will be occur within the first 12 hours of life, because of the difference in the resistant gradient ما بين pulmonary circulation و systemic circulation. بما انه صار systemic circulation اعلى صار 2 to 1 percentage to the pulmonary circulation. فهنا راح يصير عندنا shifting of the blood through left to right, يعني ما راح ينزل للاورطة. وبينما anatomical closure of the ductus arteriosus takes several days. والريمننت مالته it will be called ligamentum arteriosum. Other event, right output to flow entirely into the pulmonary circulation, as I said, and functional closure of the foramen oval. Now, because of the increased resistance of the systemic resistance, to decrease pulmonary vascular resistance, the pulmonary circulation will be increased 2 or 3 times more than fetal life. فايش راح يصير هنا البريشر in the right atrium it will be high. فهنا ايش راح يصير عندي؟ راح يصير عندي functional closure of the foramen ovale. ما راح يعبر بها البلاد from the right to left. اوكي لان هنا البريشر مالت increase. فايش راح يصير عندي functional closure of the foramen ovale, but the foramen ovale it is remain patent, probe patent من داخل بها probe, it is remain patent to the adult life. It is not closed anatomically like in the left in the ductus arteriosus to form ligamentum arteriosum. Okay, so this is very important to know because of the very high pulmonary vascular resistance, which is remain high for the first 4 to 6 months of life, or 2 to 4 months of their life. Many congenital heart diseases, كل presentation of the congenital heart diseases is depending on the gradient in the vascular resistance ما بين systemic circulation and pulmonary circulation. بما أن pulmonary circulation it is remain high because of the remodeling of the blood vessel in the pulmonary circulation for the thinning and the full opening. It is take time, about 2 to 4 months. So the most of the manifestation which is associated with right to left shunt, it is left to right shunt, sorry, it is required time for 2 to 4 months for manifestation. كل ما pulmonary vascular resistance كل ما circulation to the pulmonary tissue will be increased. هنا راح يبين إذا كان عندي defect as we discuss later. Congenital heart disease, it is classified into the cyanotic and acyanotic congenital heart disease. So we will start with acyanotic congenital heart disease. We have subclassified to the acyanotic congenital heart disease causing increased volume load. That means it will be cause more volume load on the heart. Okay? Including arterial septal defect, ventricular septal defect, VSD, atrioventricular septal defect. That, as you know, we have 2 septa which is separated vertically the heart اللي تفصل لنا right atrium عن left atrium وبها atrial septa، وventricular septa اللي تقسم لنا left ventricle عن right ventricle، وعندنا atrioventricular septa واللي هي تفصل لنا الاتريا 2 اتريا عن 2 ventricles. فهنا هذا الديفكت يسمونه atrioventricular septal defect، يعني يصير او what we call AV canal، يعني combine pulmonary and sorry tricuspid and mitral valve يصير combined valve يسمونها IV canal. Okay. وعندنا patent ductus arteriosus. The ductus arteriosus, it is the main patent which is causing left to right shunt as we discuss in the next lecture. Pathophysiology of this book it is associated with volume load. ليش؟ The presence of communication between the pulmonary and systemic circulation causing left to right shunt. هنا صار عندي pulmonary vascular resistance قلت والسيستميك vascular resistance زادت، فايش راح يصير عندي؟ راح يصير عندي left to right shunt. من يصير عندي left to right shunt ايش راح يصير عندي؟ shifting of the oxygenated blood back to the lung. يعني من يصير ejection through the systole المفروض الدم كله يروح through the ascending aorta بعدين through aortic arch to the descending aorta. هنا قسم من وين راح يروح through the ductus the communication between two circulation يرجع وين؟ يرجع على الرايت سايد فit will be increase the pulmonary circulation much more increase in the pulmonary circulation. فايش راح يصير؟ من يرجع البلاد through the pulmonary circulation through the pulmonary arteries to the right atrium هنا ايش راح يصير؟ راح يصير volume load على الهارت اكثر لانه return of the blood through the pulmonary circulation it will be doubled or more due to the shifting of the blood through the communication between the left circulation and right circulation. لذلك ليش صار عندنا الvolume overload on the heart. This, as I said, will be increased pulmonary blood flow, so it will be increased the return blood to the heart and causing the volume overload. عندنا other assigned congenital heart disease which causing increased pressure load. Increased pressure load. من الساعة كان عندنا increased volume load على الهارت. هنا راح يصير عندنا increased pressure load on the heart. هاي تشمل valvular pulmonary stenosis, aortic stenosis, coarctation of aorta, tricuspid stenosis, mitral stenosis, and pulmonary venous obstruction. Pulmonary venous obstruction. So these يعني انت من يصير عندك pulmonary stenosis يصير عندك فشنو pumping of the blood through the pulmonary artery will be limited because of this stenotic pulmonary artery. فايش راح يصير؟ راح يصير عندي more pressure on the left or on the right ventricle. ومن يصير عندي aortic stenosis يصير عندي aortic stenosis فالبريشر اللي يحتاجه الهارت على مود يدفع البلاد من الليفت ventricle to the aorta through the stenotic aortic valve, it will be causing more pressure on the heart. Also, the coarctation of aorta, when it's narrowing of the aortic arch, it will be more pressure on the left ventricle to pump blood through the stenotic aortic arch. بينما tricuspid stenosis, mitral stenosis, and pulmonary vein stenosis, حكيتها obstruction to the ventricular outflow يعني البلد اللي يطلع من الهارت واللي قلنا يصير through the aortic stenosis, mitral stenosis or coarctation of the aorta او يصير عندي obstruction to the ventricular inflow. هنا ال ventricular inflow راح يقل which is occurred in the last three causes اللي هي tricuspid stenosis, mitral stenosis and pulmonary vein obstruction. اذا عندي tricuspid stenosis ما دي يعني متغير فايش راح يصير؟ راح يطلع more pressure على الرايت اتريا to push blood to the right ventricle. ولما يصير عندي mitral stenosis هنا راح يطلع more pressure from the left atrium to push blood through it to the left ventricle. So these are cyanotic congenital heart disease with increased pressure load. يعني volume load يكون مالتهم طبيعي. هاي كلش مهمة من نجي ناخذ البرزنتيشن مالتها. Other group which is cyanotic congenital heart disease also it is subclassified in two categories. The first one cyanotic congenital heart disease with decreased pulmonary blood flow. يعني من معناها decrease pulmonary blood flow اذا عندي limitation in the right heart output. right heart output يعني بالرايت ventricle بحيث ما يصل enough amount of the blood to the pulmonary circulation. مثل ايش؟ تترولوجي اطفالات شوف pulmonary atresia with intact septum, tricuspid atresia, and total anomalous pulmonary venous return with obstruction. عندنا pulmonary venous return تكون abnormal، عندنا with obstruction or without obstruction. Okay? فالtotal anomalous pulmonary venous return with obstruction it will be cause decreased pulmonary blood flow. مثل ما تعرفون تترولوجي اطفالات تكون be associated with right ventricular outflow obstruction. فما راح يصير به pumping of the blood. pulmonary atresia with intact هم يكون بها يعني limitation of the blood to the right. Also the other causes. Pathophysiology of this group, we have obstruction to the pulmonary blood flow. We have an obstruction to the pulmonary blood flow. It will be resulting in the decreased pulmonary circulation. زين شلون راح يوصل للpulmonary circulation؟ ايش راح يصير؟ لازم اكو communication between the pulmonary and systemic circulation either through the VSD, ASD, or latent ductus arteriosus. Through it, the blood it will be goes to the it will be causing the right to left shunt. It will be causing the right يعني deoxygenated it will be returned to the heart. Systemic deoxygenation, venous blood shunt from the right to the left and enter the systemic circulation through the communication between the either it will be the foramen over ASD and VSD. هنا the circulation of the blood it will be dependent on the presence of communication between two circulation. إذا ما عندي هاي communication between the two circulation there is no systemic blood flow. لأنه البلمونري ما بي. This is what we call right to left shunt, that the deoxygenated blood it will be returned back to the left side of the body. بدل ما يروح oxygenated blood راح يدخل له deoxygenated blood لذلك يصيرون cyanosis. Cyanotic congenital disease will increase pulmonary blood flow. من ساعة كان عندي decrease pulmonary blood flow هنا عندي decrease pulmonary increase pulmonary blood flow. هاي وين يصير؟ Mainly in the transposition of the great arteries. As you know, the transposition of great arteries يكون reverse communication of the great arteries to the ventricles. That means the aorta will be connected to the right ventricle, while the pulmonary artery will be connected to the left ventricle. So the deoxygenated blood اللي يجينا it will be pushed again to the circulation through the pulmonary artery, والاكسجينيتد blood اللي يجينا من through the aorta, والاكسجينيتد blood اللي يجينا من pulmonary circulation it will be put again to the circulation. So this is what I mean by the transposition of the great arteries. Single ventricle يعني ماكو سكتة ما بين الليفت والرايت ventricle. فالاكسجينيتد blood will be mixed with the deoxygenated blood. البلد اللي جاي through the right atrium to the right ventricle راح يصير be mixing with the through the left oxygenated blood which is comes through the left atrium to the left ventricle will be mixed with the deoxygenated blood اللي جاي من the right atrium to the right ventricle. It's an intracardiac shifting mixing. Trunkus arteriosus نفس الشيء وtotal anomalous pulmonary venous return without obstruction. مثل قلنا without obstruction it will be decreased pulmonary blood flow, but without obstruction it will be associated with increased pulmonary blood flow. ايش راح يصير بهاي الجروب؟ There is no obstruction of pulmonary blood flow. Pulmonary blood flow شادي. ايش راح يصير؟ يعني cyanosis caused by either abnormal ventricular arterial connection or from the total mixture of the systemic venous and pulmonary venous blood within the heart. يعني قلنا بالtransposition of the great arteries, aorta when it is connected to the right atrium. or to the right ventricle, sorry. When the pulmonary artery, it will be connected to the left atrium. فمن يجيني blood oxygenated through the pulmonary vein يدخل لوين؟ left ventricle, left atrium, sorry. ينزل بالميترال valve the left ventricle. فthrough the pulmonary artery وين رجع؟ رجع للورك، ما راح للبدن. ونفس الفكره الديوكسجينيتد بلاد اللي اجاني من السبيلر والانفيرير فينا كيفا تو ذا رايت اتريوم ثرو ذا ترايكاسبيد فالف نزلني بالليفت فنتريكل بالرايت فنتريكل وين it is pushed again to the body through the aorta لان الاورتا هنا connected to the right ventricle فما صار عندي غاز اكسشينج فبقى ساينوسيس فهذا صار عندي كونكشن بينما بالتي جي اي ترانسبوزيشن اوف جريت ارتريز سوري هذا الشخص عندنا ميكسينج اوف ذا بلاد بينما السنجل فنتريكل قلنا يجينا البلاد عادي الدي اوكسجينيتد يجينا من السيبرال فينا كيفا وينزل بالرايت اتريوم وذاك جاينا من الاكسجينيتد بلاد جاي من البلمونري سيركيليشن وينزل من الليفت فنتريكل بس هنا because there is no septal which is separated between the two ventricles ايش راح يصير عندي؟ راح يصير intracardiac mixing لذلك الساينوسيس it will be okay. بس راح ادخل انا طبعا sorry we lost a lot of time because of the technical error فراح مني هوايه وقت ما اعتقد الى حد عد محاضره كلها فراح اشوف وين صار. Arterial septal defect الارتيريال septal defect it is represent 10% of the all congenital heart defect. We have two types of the ASD or arterial septal defect, ostium secundum, which is the most common type. The hole طبعا هي من اسمها arterial septal defect يعني اكو hole in the arterial septal. There is a hole in the arterial septal. فبالاوستيوم secundum وهي most common the hole in the region of the foramen ovale. منطقة الفورامين ovale يصير بها extra hole واللي هي تسوي لنا shifting of the blood through the hole. بينما الاوستيوم primum which is less common, the hole located near the endocardial cushion. And this may be a part of the complete atrioventricular canal. High edema, and this is ostium secundum. As you see, the hole at the side of the foramen ovale. بينما الاوستيوم primum تكون الهول it is near to the cardiac cushion, to the endocardial cushion. ويمكن تكون جزء من الاندوكارديال كيشن ديفكت لان الاندوكارديال كيشن ديفكت هاي السبته كلها تكون مفتوحه وما موجوده. اوكي؟ فالاوستيوم برايموم عاده تكون is a part of the endocardial cushion defect وذا most common هي الاوستيوم secundum. وعندنا الساينوس فينوسس which is very rare which may be associated with anomalous pulmonary venous return عادة ما نشوفه هواية بالبيدياتريك. أهم شيء الأوستيوم برايموم and ostium secundum. بعد الفيزيولوجي هنا شوية ركزوا وياي الطلاب. قلنا the most limitation of the circulation on the both sides of the heart هو البريشر جريدينت ما بين systemic and vascular systemic and pulmonary vascular resistance. إذا زادت pulmonary vascular resistance يعني shifting of the blood to the pulmonary circulation will be decreased either normally or through the communication. إذا قلت pulmonary vascular resistance ايش راح يصير عندي increase shifting of the blood from the left side to the right side والعكس صحيح. من تزداد البلمونري فاسكولار ريزيستنس اكثر من السيستميك فاسكولار ريزيستنس وهنا راح يصير shifting of the blood from the right side of the heart to the left side. فإذا manifestation of the communication between two circulation depend on the main degree of the left to right shunt يعني البرزنتيشن سوري تعتمد على الماجنتيود اوف ذا رايت شنت. ليفت رايت شنت. هذا الليفت رايت شنت يعتمد اول نقطه يعتمد عليه هو السايز اوف ذا ديفكت، ايش ما يكون الديفكت اللي هي الاتريال سبتال ديفكت، ايش ما يكون ديفكت كبير منطقيا راح يصير بها shifting of the blood more to the defect. و الكومبلاينس اوف ذا رايت اند ليفت فنتريكل مش ما تتوسع، مش ما تكون بها قابليه على التوسع، الكومبلاينس مالتها راح تستوعب مور بلاد، فاذا كانت الكومبلاينس اوف ذا ليفت اتريوم فيري هاي راح تستوعب هوايه بلاد، فالفوليوم لود راح ينكريز وانكريز ذا شيفتنج ثرو ذا سبتل. اذا الكومبلاينس قليله اكيد راح يكون الاماونت اوف ذا بلاد الداخله للليفت اتريوم قليله، فالشيفتنج ثرو ذا ASD will be decreased. وعندنا قلنا pulmonary vascular resistance and systemic vascular resistance هذا the main factor which is effect. فكل ما تقل البلمونري vascular resistance الشنت through the defect will be increased، وكل ما تزداد البلمونري vascular resistance الشنت will be limited. هسه نشوف هنا بهاي الصورة نشوف هذا هو الاي اس دي، هذا الاي اس دي الديفكت. هنا انا جاني بلاد through the heart through the pulmonary artery، اجاني هذا الاكسجينيتد بلاد الاحمر دخل لي للليفت اتريوم. ليفت اتريوم من يصير كونتراكشن اوف ذا ليفت اتريوم المفروض البلاد وين يجي؟ يجي through the mitral valve to the left ventricle، ومن left ventricle it would be pumped through the aorta during systole. اوكي؟ فهنا من يصير contraction during systole واكو ديفكت موجود هنا، اكيد قسم من الدم وين يروح through the defect إنه للرايت اتريوم، وبعدين من الرايت اتريوم وين يرجع through the pulmonary artery ويروح للبلمونري سيركيليشن. فزيد الفوليوم لود على الرايت اتريوم، وزيد لي سوى لي ليفت تو رايت شنت، يعني اوكسجينيتد بلاد عبر للدي اوكسجينيتد بلاد وراح رجع مره ثانيه وين؟ لللنج. واضح يا شباب؟ فهنا اذا كان عندي هذا الديفكت صغير الاي اس دي اكيد البلاد اللي راح يعبر من الليفت اتريوم للرايت اتريوم يكون قليل. واذا عندي البلمونري فاسكولار ريزيستنس عاليه، عاليه، اكيد هذا هم راح يشتغل مثل الكلوجر، فراح يمنع الشيفتنج، راح يسوي ليميتيشن اوف ذا شيفتنج from the left side to the right side، لذلك نسميه left to right shunt. ليش ما يصير right to left shunt؟ لانه هنا البريشر جريدنت اعلى. قلنا after closure of the umbilical cord ونكريس systemic vascular resistance اللي حكيناها بالبدايه، وافter expansion of the lung ونكريس BO2 in the pulmonary circulation راح تكريس pulmonary vascular resistance، فصارت هنا systemic 2 to 1 to the pulmonary vascular resistance، يعني صارت double of the pulmonary vascular resistance. فما يصير عندي left to right to left shunt، وانما يصير عندي left to right shunt. لما قسم من البلاد الاكسجينيتد بلاد يعبر للدي اوكسجينيتد بلاد وبعدين بامب اجين تو ذا لنج. شنو اللي يقلله او يزيده؟ السايز اوف ذا ديفكت. كل ما يكون كبير اكيد هنا ثرو ذا كونتراكشن اوف ذا هارت راح يكون عندي قسم من البلاد يجي لهنا، و الجريدنت بالفاسكولار ريزيستنس ما بين التو سيركيليشن، كل ما تقل السيستميك البلمونري فاسكولار ريزيستنس راح يكون عندي مور شيفتنج اوف ذا بلاد، والكومبلاينس اوف ذا هارت كل ما يكون عندك قابليه على التوسع الليفت اتريوم راح يستوعب هوايه بلاد من البلمونري سيركيليشن، فراح يبوش مور بلاد اجين تو ذا رايت سايد اوف ذا هارت. واضحه الباثوفيزيولوجي شباب؟ مالت الاي اس دي؟
واضح.
احد عنده سؤال استفسار على الباثوفيزيولوجي؟ عيني؟ ماكو سؤال ان شاء الله؟ اوكي. هاي حكيتها انا قلت اذا large defect considerable chunk of the oxygenated blood from the left to the right atrium will occur, and this blood will be added to the usual venous return to the right atrium and is pumped by the right ventricle to the lung again, so it will be increased pulmonary vascular resistance. صوت واضح الصوت شباب؟
واضح دكتور.
سمعوني مو؟
واضح دكتور.
Okay. With large defect, the ratio of the pulmonary to systemic blood flow, it will be between 2 to 1 and 4 to 1. كل ما يزداد النسبة ما بين pulmonary to the systemic blood flow, the manifestation will be more severe. Clinical features. ASD is often asymptomatic and discovered during physical examination, routine physical examination. Even extremely large ASD, it is rarely produce clinical heart failure during the childhood, but subtle failure to thrive may be present due to the mild heart failure. And various degree of the exercise intolerance might be present in the older children. يعني بين قوسين it is asymptomatic, بس بالروتين examination, unilateral examination يمكن أن تسمع المرمر of the ASD وهذا اللي يخليك تمشي ويا الدايجنوزس. واللارج ASD ما تسوي لنا heart failure, severe heart failure, بس يمكن سنة subtle failure to thrive. And بالchildhood يمكن يصير عندهم exercise intolerance, بس يلعب شوية وهذا الطفل راح يتعب. بالexamination there might be mild left precordial bulge due to the cardiomegaly. تعرف انت هنا الرايت atrium صار عليه لود هوايه الفوليوم لود والرايت ventricle also اللود it will be increased فراح يصير عندي right heart side hypertrophy cardiac hypertrophy فراح يصير عندنا precordial bulge يعني bulging at the region of the precordium. right ventricle impulse can be palpated لانه هنا قلنا الفوليوم مالته انكريس فلما تخلي ايدك بوضوح راح تحس الحركه مالت الرايت ventricle because of the volume load. هذا lower sternal boulder. بالاوسكلتيشن راح تلقى fixed splitting of the S2 اللي هاي important. طبعا السبليتنج of the S2 يكون مو fixed عاده يصير during diastole ويختفي during systole. بس إذا صار fixed splitting through the systole and diastole فهي cardinal sign of the ASD. We have soft grade 1 or 2 systolic ejection murmur. Systolic ejection murmur اسمها at the middle and upper sternal border due to the increased blood flow across the right ventricle into the pulmonary artery and not due to the low pressure flow across the ASD. ASD per se ما يصير لك مرمر، ما تسوي لك مرمر، هاي نقطة كلش مهمة بالام سي كيو. ASD per se there is no مرمر، بس ايش راح يصير عندي؟ راح يصير عندي increased pulmonary blood flow وراح يرجع more blood to the right atrium بعدين to the left ventricle فراح تسمع systolic ejection murmur due to the increased blood flow through the pulmonary artery. فالمرمر تسمعه due to the increased blood flow through the pulmonary artery يعني blood flow يكون اكثر من قابليه استيعاب البلمونري artery فراح يصير عندك المرمر. من تجيك هاي systolic ejection murmur it is due to the passing blood through ASD قلنا لا خطأ. ASD نفسها ما تسوي مرمر بس المرمر يجيني due to the increased blood flow through the pulmonary artery. مرات اسمع mid diastolic murmur at the lower sternal border due to the increased flow across the tricuspid valve. هم قلنا الفوليوم مالت البلاد اللي يرجع للرايت اتريوم يكون عالي فاكيد راح يكون increased blood flow through the tricuspid valve اكثر من قابليته. والمرمر ليش يصير؟ المرمر يصير due to the passing of the blood through the narrow opening. هنا لانه التراكاسبيد فالف تكون قابليته لاستيعاب الدم اقل من ما يجي من الرايت اتريوم فراح نسمع عنده ميد دايستوليك مارمر مشابه للترايكاسبيد ستينوسيس، مشابه للترايكاسبيد ستينوسيس، بس هو الفالف نوت ستينوتيك، بس البلد الجاي خلاله اعلى من قابليته. اذا تسمع مرمرين بالاي اس دي، واحد سيستوليك ايجكشن مرمر مشابه للبلمونري ستينوسيس but it is not due to the pulmonary stenosis, it is due to increase of blood flow through the pulmonary artery. وتسمع mid diastolic murmur at the tricuspid area which is not due to the stenotic tricuspid وإنما due to the increased blood flow through the tricuspid valve. شلون نسوي لها diagnosis؟ شلون نسوي لها diagnosis؟ chest x-ray راح اشوف بها كارديوميغالي من الرايت سايد، right atrial enlargement and prominent pulmonary artery with increased pulmonary blood flow as in this picture. هنا نشوف right atrial hypertrophy، زين، increased prominent pulmonary artery، هذا pulmonary artery with increased pulmonary circulation. هذا الابيض هو كله increased pulmonary circulation. هذا عندي right atrial hypertrophy، right atrial hypertrophy. هنا عندي prominent pulmonary artery with increased pulmonary vascularity. هذا الابيض اللي نشوفه باللاين هو due to the increased pulmonary vascularity. The ECG will show right axis deviation and right ventricular hypertrophy. Echocardiography will be demonstrate the definitive size، راح يعطيك السايز مالت الديفكت، وراح يعطيك اللوكيشن whether it is primary or secondary، وراح يعطيك البلمونري circulation يقيسه إليك والسيستميك circulation هم يقيسه إليك. Treatment مالته it is asymptomatic child required no treatment but transcatheter or surgical closure it is indicated in video واضح. All symptomatic children in asymptomatic patient with pulmonary circulation to the systemic circulation ratio 2:1 and more, and severe right ventricular enlargement. These are indications for the surgical or transcatheter closure of the ASD. Can the symptomatic child, it's an asymptomatic child, but a ratio of the pulmonary to systemic circulation 2:1 or more، لأنه راح يصير pulmonary hypertension هاي نقيسها بالإيكو، وإذا صار في severe right ventricular enlargement. البروجنوسيس small to moderate ASD in term infant may close spontaneously. Where secondary ASD is well tolerated during the childhood, while complication occur at the third decade of life or more, including pulmonary hypertension due to increased pulmonary blood flow, with resulting in the hypertrophy of the pulmonary blood vessel and resulting in the pulmonary hypertension. Arterial dysarrhythmia, which is common in the third decade of the life. Tricuspid or mitral insufficiency due to the increase of blood flow through these valves, and heart failure, which is occurred on the third decade of life. These are about the ASD. So, عندكم محاضرة بعدها؟